All right, we've been through a lot together, talking through all the types of biases and confounding that can get into the medical literature. And so I want to take a little break, a little breather, and just do some one-off, quick, what I call statistical brain teasers, just to flex your brain a little bit, some real and imaginary studies where there's a subtle problem that might not be obvious on the surface, and just to think through it a little bit. So our goals here are to have some fun, wrinkling our brains, remind ourselves that the intuitive explanation of data is not always the correct explanation, and to be really careful about our assumptions whenever we read a study. So we're going to start with a really common problem. Why are all the pretty ones mean? You felt that way sometimes? You know, there's the nice guy and the nice girl and the pretty guy and the pretty girl, and there seems to be this like inverse correlation. Well, there's not. But here's why you think that is. So I'm going to walk through this with you. This is something called Berkson's bias. It's pretty fascinating. So imagine with me that each of the dots in this graph is a person, and we have ranked them on a scale of 0 to 1 in terms of niceness and 0 to 1 in terms of prettiness. Okay, so every dot represents a person, and you can see they're kind of all over the map. There's no relationship here. There's no line. It's just a cloud. Everyone kind of gets a random dose of prettiness and niceness. So far, so good. Now, ask yourself the question, among this group, who would you date? Think about it for a second. You may even want to pause the video. Think about it for a second. What you may say is that there's some combination of niceness and prettiness that you would deem acceptable. In other words, you're not going for this guy way down here on the bottom left who's pretty mean and pretty ugly, but you're willing to tolerate maybe a bit more meanness if the person is better looking, or a bit less nice lookingness if the person is nicer. And in fact, you may decide that your threshold is somewhere here. So you can see the red people here are the unacceptable people. They sort of fall below this line. So does that sort of comport with your own intuition? Okay, take those people out of the picture because you've deemed them unacceptable, and now look who is left. When you look at this population that's left, you do see a correlation. You can see that there's a clear negative correlation between niceness and prettiness. It is not real. It is a product of your selection. It is because you won't even consider the mean, ugly people at all. You don't even think about them. That is Berkson's bias. It's a form of selection bias, but it creeps into a lot of different places, both in the medical literature and in your love life. So to sum up, two uncorrelated variables appear to be correlated because of their mutual relationship with some third variable. In this case, that third variable is your taste in men and women. It's often called collider bias. You might see it referred to as that. It's commonly seen in hospital case control studies where admission rates differ. So for example, a hospitalized patient without diabetes is more likely to have cholecystitis than a hospitalized patient with diabetes. Okay, so if you looked in the hospital, you'd find that most of the patients with cholecystitis, gallbladder infection, don't have diabetes or are less likely to have diabetes. Does that mean that diabetes protects you against cholecystitis? No, it's because people with diabetes get hospitalized more often for everything. So because you were only looking in the hospital population, there are a lot of diabetics there for a lot of reasons, whereas people there for cholecystitis are just there for cholecystitis. Transplant studies. Why might diabetes in a donor appear to be protective in terms of recipient outcomes? So if I'm going to donate a kidney, and let's say I have diabetes, they generally don't let diabetics donate a kidney, but for purposes of this example, you might actually find that that is a good thing. And the reason is that the surgeon is only going to use that diabetic kidney if everything else is perfect, if everything else about that kidney is 100%, right? And so there's that selection underneath. The surgeon is picking the kidney much like you pick your dating partners, okay? And so these types of biases come in. They're pretty subtle, but it's definitely something to think about. Next. Where there's a will, there's a way. Let's imagine that a new imaging test for cancer has been developed. Think Star Trek. It's super high-tech. It can scan your entire body and see the tiniest little cancer cell. It detects the spread of cancer with much greater sensitivity. You know exactly where all the cancer is. We do a trial. we find that people diagnosed using this test for any stage of cancer do better than those diagnosed using a conventional CT scan. So we are super happy, right? Every single stage of cancer does better. Well, that's great. Except what if I told you that overall there was no difference? What happened? Think about this one for a little bit, but it'll wrinkle your brain. Well, this is called Will Rogers phenomenon. It's also known as upstaging. Will Rogers once said, when the Okies left Oklahoma and moved to California, it raised the IQ of both states. Think about that for a second. I think it's pretty clever. All right. What's happening here is that your Star Trek test is more accurate at seeing where the cancer is, and because of that, it's likely to upstage people. So stage 1 cancer is typically a very small localized cancer. Well, your Star Trek test, well, your CT might think it's a small localized cancer, but your Star Trek test is going to move some of those people from stage 1 to stage 2, because it's going to find a little cancer somewhere else. Now think about what the death rate is going to be in stage 1 and stage 2. Well, in your Star Trek test, you took kind of the worst stage 1s and put them in stage 2. So stage 1 looks better. Simultaneously, you took some of those stage 1s and put them in stage 2. They're now the best of the stage 2 people, so stage 2 does better as well. And you can carry this across the whole way. And if, in fact, if you do this math, what you'll see is that for each stage of cancer, the overall mortality rate has gone down, and yet the overall mortality rate is 10% in both groups. Really, really counterintuitive, but do the math yourself. I worked on it carefully. You'll see that it's correct. So this is called upstaging. You've got to be really careful about it and not just look at the survival rates by stage. So it's commonly seen in new imaging and diagnostic test studies. You upstage people with stage 1 to stage 2 and so on. It makes stage 1 look better and stage 2 look better, and all of a sudden your imaging test improved outcomes. Be wary when anything is stratified by stage. It can creep in easily. You always want to see not only the stage stratified results, but the overall results. A similar phenomenon happened in 1973. Berkeley was sued for gender bias against women based on this statistically significant finding. They found that 44% of male applicants were admitted compared to 35% of female applicants were admitted. So overall, those were the results. But then when it was stratified by department, you can see here department A through F, what they found actually is that in 4 out of the 6 departments, women were admitted preferentially, and in 2 of the departments, the men were admitted preferentially. And so what it turned out was that women were applying overall, in terms of the department that they were applying into, were applying in departments with slightly higher acceptance rates overall. And so there ended up becoming a difference between the overall acceptance rate and the department by department level acceptance rate. Another example where staging, stratifying people, can give different results than the overall results. Another example in my world, which is, again, really counterintuitive, was looking at the treatment of kidney stones, renal calculi, by 2 different treatments. It says treatment A and treatment B here. And it's really interesting. And what they did is they looked at the effect of treatment A versus treatment B on small kidney stones and large kidney stones, and they looked at the overall effectiveness, which treatment was better. Well, among the small stones, treatment A cured 93% of them compared to 87% of treatment B. In terms of large stones, treatment A cured 73% of them compared to 69% of treatment B. So for both small stones and large stones, treatment A did better. However, overall, the total cure rate was 78% for treatment A and 83% for treatment B. So what was happening here? It's really strange, right? It kind of like hurts your brain. Well, what's happening here is that treatment A and treatment B are being applied differentially based on the stone type. You can see that there were 270 cases where treatment B was used for small stones compared to just 87 of treatment A. Treatment B was used in only 80 cases of large stones compared to 263 cases of in treatment A. So treatment A is preferentially being used for large stones. Treatment B is preferentially being used for small stones because small stones are sort of easier to cure. The fact that treatment B is used so much more often meant that overall, treatment B looks better. But nevertheless, treatment A has a higher cure rate in each of the strata. Are you confused? You should be confused. And I kind of want you to be confused about all of this because it shows you that your intuition about how to combine numbers and percentages in studies like this just may be flat out wrong. And you really want to see the data for yourself. This is commonly seen in treatment studies where the severity of disease dictates the treatment strategy. Okay, so if mild disease gets a certain treatment, and more serious disease gets a different treatment, you will often see that the treatment that is preferentially given to the minor disease works better overall, even if the more intense treatment would work better if you did it for the mild disease. Really, really confusing, interesting stuff. The solution here is to look for stratified analyses. So I gave you an example with the Will Rogers phenomenon where you need to take the stratified analyses and look at the total, and I'm giving you an example here where you have to take the total analysis and look at the stratified analyses. You need both, and you need to think about what's missing from a study if they don't present it. This one's a little more straightforward. So here's a study talking about antibiotic prescribing. And basically, what it was looking at is the rate of antibiotic prescription for children with upper respiratory infections. You're not supposed to prescribe kids antibiotics for upper respiratory infections. It's an inappropriate use of antibiotics. And so what this study was is they conducted a survey to assess provider behavior patterns. So they asked providers, hey, how often do you prescribe antibiotics for upper respiratory infections? And what would you do in a kid who had a fever and an upper respiratory infection? And what would you do if the kid, was out of school for 3 days? And all that kind of stuff. It was just a survey to get their behavior patterns. Look what happened to the antibiotic prescribing rates before the survey, 46%, during the survey, 17%, and after the survey, 37%. So what was going on there? Well, this is something called the Hawthorne effect. It's present in all sorts of studies in biomedical literature. What it is that the act of observing something changes it. It's almost like the quantum mechanics of the medical literature, okay? These docs were getting a survey. They knew people were looking to see how much antibiotics they were prescribing, and so they changed their behavior. They prescribed less antibiotics. When the survey ended, they went right back to their old habits. So you'll see this a lot in studies where there's some behavior that people are trying to change, often like hand washing or something in the hospital. And during the study, the behavior gets better, and then when the study ends, the behavior gets worse. So be aware, Hawthorne effect can definitely creep in quite easily. A subject behaviors or outcome change due to their knowledge of being under observation. Okay, you're feeling like a guinea pig. Commonly seen in quality improvement studies, and the effect often goes away when the study ends. All right, next one. The World War I helmet mystery. After the introduction of helmets in World War I, the rate of head injury rose dramatically. So why were people coming home with worse head injuries after helmets were started in World War I? So the answer is not that they had a helmet on, they felt brave, and so they were charging into battle because they had their helmet on. The answer was that prior to helmets, people were dying more. And so this is an example of survivor bias, okay? So what was happening before people were wearing helmets is that if there was a big detonation near you or something and you got trauma in the head vicinity, you would generally die on the battlefield, and that wouldn't be recorded as a head injury, it would be recorded as a death. Now people were surviving and making it back home, they had all these head injuries. You can see the same thing if you look at the introduction of seatbelts in automobiles, right? The mortality rate goes down, but the rate of injury in accidents goes up. It's not because people are driving more crazily, it's because they're surviving more. Here's an example in the medical literature of some survival bias. This is a study that looked at temporal changes in therapeutic exposure on self-reported health status in childhood cancer survivors. It appeared in the Annals of Internal Medicine. This was a study that looked over a long period of time at kids who had cancer and got treatment and survived, and then looked at how they did in sort of their midlife times. And what they found is that in more modern eras, these people had worse health in their midlife. In other words, if you were diagnosed with a childhood cancer in the 1970s and survived, you'd be doing pretty well when you got to age 40 or 50. If you were diagnosed with a childhood cancer in the 2000s or the 1990s and you made it to age 30 or 40 or 50, you survived, you weren't doing quite as well as had you been diagnosed beforehand. And the implication of the study, at least as the author said, was, oh, well, this means that, like, we are not doing good enough to take care of these people throughout their lives, that they're getting sick from other things. We need to take better care of them. In fact, what this might be is a World War II helmet problem, a World War I helmet problem. Our treatments for childhood cancer are getting so good that we are taking people that normally would have died of their cancer and never made it to 30, 40, 50 years, and now they're survivors. So you're taking kind of people that were sicker to begin with, and you're converting them into survivors. It makes the survivors look worse over time. Regression to the mean is a super common problem. You've probably heard this tossed around a lot. You might not actually know what it means, but can happen all the time in medical studies. And the thing you have to be aware of is that any study that enrolls people based on like some threshold, and that threshold could be anything. It could be a pain level or a systolic blood pressure level or something. People are more likely to be enrolled when they're above the threshold, or in fact, they can only be enrolled when they're above the threshold. Well, here's an example where I've got someone who has a pain score, and it kind of bounces around, right? Some days they have better pain, some days they have worse pain. Well, they can only get into the study when they have pretty bad pain, because the study's exclusion criteria say, oh no, you need to have pretty bad pain to be in this study. Well, if people are bouncing around, but you only enroll them when they're high, the chances are they'll go lower over time. That's regression to the mean. So you capture them at a high point, and then chances are they just kind of come back to their mean, their average over time. So in studies of this type, you got to be careful, because everyone's pain is going to be bad when they come into the study, and everyone's pain is going to get better over time. Now, if you randomize them to a treatment versus control, the thought is that the pain might get better in the control, but it gets even better in the treatment arm. But in non-randomized studies of this type, you'll see everything gets better, and it doesn't just have to be pain. If you enroll someone in a blood pressure trial, the blood pressure will come down over time, even if you don't do anything, because you only enroll them when their blood pressure is high. Let's not forget confounding by indication, which of course we talked about in our confounding lecture, but it never hurts to reiterate, which is when you have a treatment that's associated with the severity of the disease. So you get a drug because you have a really bad high blood pressure, and of course because you have really bad high blood pressure, you're going to have a worse outcome, and it makes it look like the drug is causing the bad outcome. So we get away from that by randomizing people or using adjustment, as we talked about in the past, although we have to be so careful with adjustment. All right, now your brain probably really hurts. The main takeaways from this is not that you have to memorize all these different types of weird statistical paradoxes. It's just to remember that what seems obvious or intuitive may not be on further reflection. Be really careful when a study isn't randomized. A lot can go wrong in that case. Ask yourself if it's important to look at the effect across strata, broken down into groups, or in aggregate. And often the answer is you want to look at it in both to make good inferences. And finally, when in doubt between dating a prettier person and a nicer person, always choose the nicer person. That's the most important thing. I'll see you next time.